for the next talk, I would like to invite Professor Vinod Kumar, sir. Sir is currently working at the prestigious RP Center. He is well-awarded researcher and a great medical teacher. Sir is going to talk about the clinical insights of OCTA in diabetic retinopathy and retinal vascular pathologies. Over to you, sir.
Good morning. So I'll be talking about OCTA in vascular pathologies, and mainly I'll talk about diabetic retinopathy. At the outset, I'd like to thank Ankur for having me in this course. We know that when we assess diabetic retinopathy, we have certain standards of care, and we very commonly use OCT. We use commonly fundus photography, and gold standard is fluorescein angiography, which has been there for long. Of late, I think for past decade or so, we have been using ultra-wide field imaging, and I think again it has changed the way we look at diabetic retinopathy, because while it was considered a predominantly mid-peripheral disease, now with ultra-wide field angiography, we know that diabetic retinopathy is not limited to posterior pole, and it can extend to the periphery of the retina as well. Now, rather than talking just from the literature, what I would like to share you with is the study we did at our center sometimes back. It was thesis work of one of our candidates, Dr. Nawazish. She is now faculty with us. So what this study planned to do was compare diabetic retinopathy changes as we see them on fundus fluorescein angiography versus what we see on OCT angiography. And we also tried to see if there were any differences on OCTA between eyes who had diabetic retinopathy clinically and the eyes which did not have. So this study was conducted at RP Center. It was a cross-sectional study, and we performed this study after obtaining an ethical clearance from the ethics committee of the AIMS. We had 3 study groups. The group 1 had 30 diabetic patients without any diabetic retinopathy. Group 2 had eyes with non-proliferative diabetic retinopathy, and these eyes may have diabetic macular edema or not. And group 3 had diabetic patients who had proliferative diabetic retinopathy. So this is how essentially workflow of the study was. The eyes where we had no diabetic retinopathy underwent fundus photograph, spectral domain OCT, and these eyes also underwent OCT angiography. However, we did not do any fundus fluorescein angiography in these eyes because we thought it was not required. Eyes with NPDR were divided into 2 subgroups, while the eyes where there was no diabetic macular edema underwent again the same set of investigation, that is fundus photograph, OCT and OCTA. Eyes with DME underwent additional FFA as well. On the other hand, the subgroup with PDR, all eyes underwent fundus photograph, OCT, OCTA and FFA. So what we did is we compared what was seen on FA versus OCTA, and there was a little difference here because the FFA was done considering using standard cameras, while OCTA was done using 8 into 8 mm OCTA scans. Now Zeiss Angioplex was the machine which was used. It gives us 3x3, 6x6 and 8x8, and for this study we used 8x8 OCTA images. And what we assessed was various changes of diabetic retinopathy in terms of microaneurysms, size of FAZ, capillary non-perfusion areas, leakage, irmas and neovascularization. So as I said, these are the various things we assessed, and I'll show you how we fared, how OCTA fared compared to FFA in these eyes. So first, talking about microaneurysms, almost all OCTA scans showed microaneurysms where they were visible clinically, but one predominant difference was when you do a color fundus photograph, you see some amount of microorganisms. When you do FFA, you see many more, but that is not true with Octa. On Octa, you see much less number of microorganisms, and that is why we know that while CP color photograph underestimates the number of microorganisms, Octa also underestimates the number of microorganisms. Now FFA being the gold standard detects most number of microorganisms. So this is a patient with, you can see, moderate NPDR. There are some hard exudates and microorganisms which are visible, but when you go on to do Octa and FFA, you can see on FFA many microorganisms are seen, while the same are not seen on Octa scans. So just highlighting the fact that the number of microorganisms which you see on FFA are more than what you see on clinical, and what you see on Octa are much less in number. So another patient, you can see many microorganisms are visible on the corresponding FFA scans, but if you see the Octa scans, the much lesser number of microorganisms are seen. So what was very different in this particular study is that even in eyes where there was no clinical diabetic retinopathy, we found that Octa could detect some amount of microorganisms. So this is a patient, you can see there is hardly any diabetic retinopathy which is visible on clinical photographs, but when we went on to do Octa in these eyes, you can see there are distinctly visible microorganisms which are there, and thus signifying that what you can see on Octa may not be visible on fundus fluorescein angiography. Now traditionally we have not been doing FFA when there is no clinical diabetic retinopathy. If we do fluorescein angiography in these eyes, we might be able to detect these microorganisms. Next was FAZ. FAZ shape and size we all know can be calculated on OCT scans. One important difference compared to FA is that when you do FFA, there is leakage of dye, and that will lead to fuzzy borders of FAZ, and you may not be able to accurately calculate the size of FAZ. But on Octa, we found that in all the patients we could accurately detect the size of the FAZ, and these are the various values we obtained. As Devesh highlighted, the various quantitative parameters we saw was vascular density and perfusion density, and we saw that as the grade of diabetic retinopathy increased, all these quantitative parameters decreased, signifying that there is some amount of change even when the size of the FAZ is normal. Now what was very important here is that what we could see is something called posterior or parafoveal CNPs. Now this is a patient, if you see there is minimal diabetic retinopathy, few microorganisms, but if you see there are capillary dropout areas which are there close to the fovea. Now these have been studied extensively, and people have found out that whenever you have these posterior capillary non-perfusion areas, these signify that the patient is likely to have high risk of progression to meaningful clinical diabetic retinopathy. So then is coming to leakage, and as Devesh highlighted, leakage can only be assessed on fluorescein angiography. Peripheral CNPs, yes, they can be seen on Octa, but the limiting factor as of now is that we cannot do wide field Octas. So what the view we can get on FFA, you cannot get on peripheral on the Octa. So it is the most important drawback, and I personally feel as the technology evolves, as we'll be able to image the peripheral retina with Octa, this deficiency of Octa would be resolved. So this is a patient, you can see there are many CNPs, and when you go on to do wide field Octa in these eyes, you can very well see neovascularization as well. So with currently available Octa machines, since we just image the posterior pole, not all peripheral NVs can be picked up, but when you have wide field Octa which is reaching up to the mid-periphery, you can pick up these neovascularizations very well. So this is a patient, you can see there is a neovascularization. So when you do the segmentation at the vitreous level, you can see that this neovascularization is in the vitreous cavity, signifying that this is a raised NV. So, to summarize, we found that there is quantitative decrease in the vascular density and perfusion density in superficial plexus as the severity of the disease increases. Also, the size of the FAZ increases, which we know already. OCTA can help us in the detection of microorganisms even in patients where there is no clinical diabetic retinopathy. We have certain patients where posterior CNP areas can be detected on OCTA and they are better visualized on OCTA, and it signifies high risk of progression in patients with diabetic retinopathy. And as is known, again, increase in FAZ area, distortion and macular ischemia is better visualized on OCTA as compared to FFA. And remember, when you assess FAZ in these patients, it's always best to assess FAZ in deep capillary plexus and not superficial capillary plexus. So as of now, FA remains gold standard for assessing patients with non-proliferative diabetic retinopathy. Because FA is a dynamic process, one added asset of OCTA is leakage, and as of now FFA provides wider field, allowing us to pick peripheral CNPs and peripheral neovascularizations. OCTA is a very useful non-invasive tool. It shows some changes even in eyes where there is no clinical diabetic retinopathy. It can be used to monitor progression in patients with diabetic retinopathy and is very useful indicator of macular ischemia. Thank you very much.
Thank you so much, sir. Excellent talk as always. I'd like to ask you something about the characteristics of neovascularization over the disc on OCTA. Just by looking at the OCTA image of a NVD, can you say that it is an active NVD or a regressing NVD which has already formed collaterals?
I think it's just based on the size. There's no definitive way to say, because if you do OCTA through various, fibrovascular proliferations where they are all fibrous, even then you will see some vessels which are remaining, as we see in choroidal neovascularizations also. So when it comes to NVD, if you see many small vessels which are running randomly haywire in all the direction, it is likely that this NVD is active. But if you have large vessels which do not have predominant branching patterns, so you can assume that this is healed or resolved NVD. But again, I think you cannot undermine the importance of leakage here. That is a very important feature which you see on FFA.
Thank you, sir. So just one more query in diabetic retinopathy, the utility of OCTA. As now the OCT angio devices are becoming cheaper and they are more readily available, more number of companies bringing in OCTA. How in your practice, what do you advise any patient who comes with diabetic retinopathy, one, any patient who comes with diabetes mellitus, two, any patient that comes with PDR or or without CSME, do you advise OCTA in patients all? Do you want the patient to be assessed because it's a non-invasive? Any patient who comes with diabetic retinopathy may not have an CSME or the clinical diabetic retinopathy per se. Would you ask the patient to undergo OCTA, or do you plan it to do in a certain set of patients, or you plan to do FFA as a baseline and then follow up on the OCTA? So what is your practice?
So I'm, to be honest, I'm still follow old school. So because neovascularization and the peripheral retina is something which we really can't assess with OCTA as of now. So I still do ultra wide field fluorescein angiograms in all my patients with clinically meaningful diabetic retinopathy which needs treatment. So this allows me to document the disease process, and I do OCTA usually at baseline only in patients who cannot undergo FFA. So eyes with deranged KFTs, the patients with deranged KFTs, the pregnant patients. So wherever the patient is not fit enough to undergo FFA, thereby I perform OCTA, and usually we ask our technicians to take montage images of OCTA so that at least till the mid periphery we are able to see. I think with the onset of anti-VEGF therapy for macular edema, We are not that concerned with macular ischemia nowadays. We nowadays do not pay that much of attention to FAZ, which we used to pay earlier when the anti-VEGFs were not there.
So would you recommend doing OCTA in mild or no DR cases and then look at these parafoveal CNP and then maybe change the follow protocol?
Yes, clinically it makes sense, but as I mentioned, even if eyes with no DR progress, they are first going to progress to mild NPDR only. So as of now, since we do not have any treatment for mild to moderate NPDRs where there is no macular edema, so it may not be clinically relevant, but as the time progresses, I think in coming decades, when we have treatment for diabetic retinopathy in mild and moderate, there might be some usage.
Maybe just predicting who will go into meaningful DR.
Yes, definitely, definitely.
Any questions? Thank you, sir. Thank you for enriching us with such a detailed talk on diabetes.